So thank you, of course, for the invitation from the Gulf Intervention Society. So I think we recognise that the cath lab is a complex world. Here's an example of sort of the problems that we deal with and the things that we are used to seeing. Here's a patient with left main disease and a CTO, and you can see videos of some PCI on the right. Doesn't usually tell the full story. We don't see video number 1 with the tortuous subclavian that we've just been negotiating for a while, or number 87, which was taken 3 hours later, dealing with an unsettled, difficult patient with operator fatigue. And within this environment, we're expected to make multiple decisions, and it's difficult. And as we've just seen, there are lots of things to consider. What should I do? What does the data show? Interpreting the information that we're receiving real time, and that's difficult. But as Prof. Spratt has just showed, there are other things happening. This was what happened to me last week. There's a STEMI coming, the patient was unsettled, and there's lots of things to juggle at the same time. A lot of sensory overload, and as we've talked about, this creates somewhat of a storm of things to consider, balance and prioritize. So how do we go about processing information in the cath lab? Well, how do we make decisions in general? We sense information, we process that information, and usually through some sort of value-based or objective judgment, we try and come to a decision. And in an ideal world, we take that information that's accurate, complete, that we can understand, and come to a decision that hopefully is in the best interests of the patient. But in the real world, that's not always the case. As we've seen, information can be incomplete, corrupted, and it makes cognitive processing of that information more challenging, leading to often different decisions, variable outcomes sometimes for patients. And really, variability isn't explained by fancy equipment. Actually, a lot of it is to do with people, us, and the way we process information. So this is a patient who's arrived on the table with risk factors, a history of previous PCI, and he's presented with an NSTEMI. I'm going to show you his angiogram, but before that, we're going to get participating in a little exercise. I'm going to split the room. So all of you on my right, you're going to have to stop looking at your phones for a second and start performing this exercise. I'll ask my colleagues on the panel to do so. So everyone close to me, on my right, start practicing this. I can see about 3 people doing it. Is that because it's too challenging? You're an interventional cardiologist, you can manage. And everyone on the left, do nothing. Keep going. I'm going to show you the angiogram while we do this. Keep going. So here's the angiogram. And again, I'm not going to describe it to you. You're all highly skilled experts and you can have a look. Let's go to the polls. Get your cameras out. You can stop doing the exercise now. That would be asking too much. Point your phones at the QR code. And to move the session on, I'm just going to give you a few seconds to do that while you choose whether you're treating this patient with tablets, an NC balloon and an IVL balloon, atherectomy up front, or you're taking on the CTO PCI. When most people's phones are down, I'm going to switch to the results. Off you go. Actually, not a lot of variability. Here we go. Some more results coming through. Next poll, if we switch back to the slides. I wonder how confident you felt making that decision. Okay, let's switch back across. Everyone felt moderately confident. Some people felt slightly confident. And there's more of a spread as people wake up. Okay, let's go back to the slides. Now, I would wager that those people doing the exercises probably had a slight reduction in confidence because you were doing other things. But there are other things to consider outside the angiogram. It's not just the angiogram. What if this patient had limited radial access, other significant comorbidities to consider? Actually, you could argue that these are potentially more important than the angiogram themselves in your decision-making process. And we are dealing with really complex problems. We're dealing with patients in the lab, we're dealing with our own goals, the patient goals, and trying to get a good outcome for these patients. And what we find is, while we maintain focus, we can lose perspective. So this is me struggling after rotablating the LAD to deliver a stent. I'm trying really hard, I'm focusing in on some of the issues here, but actually focus can narrow, you lose perspective, and there I for some time missed a distal wire perforation. And that's partly because we've got limited bandwidth. There's a real bottleneck. There's a lot of information out there, as we've seen in the other slides, for us to try and process. And we use that by referencing this against our long-term memory. So a very quick exercise. I'm going to show you these numbers. Have a look. Do consider this as a test of your intelligence. So do participate. Look at these numbers, remember them. I'm going to ask you how many you remember subsequently. 1, 2, 3, they're gone. Now count backwards from 100 by 17. I'll get you started. 83. Keep going. I have a feeling none of you are doing this with me. This is clearly a distraction technique. But let's do a show of hands. How many people could remember at least 5 of those numbers? I've seen the slide, so I can. 1. 6 numbers remembered? Anyone? No, we're still asleep. Well, that's not surprising, because actually our working memory is limited to about 7 working slots. So these are the amounts of information we can hold at any one time. But in reality, when information is discrete or different, actually it comes down to about 3. So managing the subclavian tortuosity takes up 1 slot entirely. What the patient's EGFR is takes up another. And bad news, that's stolen. Those working slots are reduced by things that we've seen we encounter all the time. Being tired, being emotional, being distracted. And this is the biggest thief of them all. Doing things with our hands steals memory. And also we rely on heuristics. What are they? Well, we use them all the time actually. An example would be crossing the road, driving a car. They allow us to make quick decisions without having to really ponder and think. But while they're good enough, they can be inaccurate. And we rely on these mental shortcuts more frequently in certain scenarios. And this can introduce bias. Well, I've managed the last time. There was a complication with that distal LAD. It'll be fine. Or I've done it this way forever and it always works. Or don't worry about another IVUS. I know that that balloon was fine. So how do we tackle this? We've got to try and zoom out and maintain perspective. Well, firstly, it's important to recognize that these are overlapping challenges. Deciding and doing share the same cognitive space. And what we're trying to do is separate these out. So what if we could decide before we started doing? Take the gloves off and then make a decision. Here are the numbers that you saw. I'm not going to make you do that again, but here they are in a more palatable format. And I would be willing to wager that most of you are more likely to remember these numbers when they're presented to you in this format because you're used to seeing them and you're drawing from your expert long-term memory. I'm not going to make you do this. I was disappointed by the 17. So here are some final thoughts. There is lots of information that we are open to. We've got to find a way to process these, and by separating thinking, deciding, away from doing with your hands is how to get a better outcome for your patients. And that's where the concept of proactive PCI comes. Trying to separate these out, and we're going to move on to the next talk where we can focus a little bit on our goals, strategy, how we set up for success for us and the patient, and thinking about ways to bail out. Thank you very much.